those of you that have not met me, my name is Jack Jacobs. I'm a GP in Ham Street in East Kent. I'm also medical director in Kent, LMC, and I'm joined by Maya Vibhuti and Dan Clements. Do you guys just want to introduce yourselves and your roles?
Sure. So, hi everyone. I'm Maya Vibhuti. I'm a GP. I work clinically in Medway, but I'm also CCIO, which is Chief Clinical Information Officer for the ICB, which is like a digital role.
Thanks, Maya. And Dan?
Yeah, Dan Clement. I'm the Associate Director, Information Governance for the system and Data Protection Officer for the ICB as well.
Great. And thanks very much. I really appreciate you two joining us today. I know that this topic is a hot one, and we get a lot of queries about it in the LMC. And I just wanted to sort of reflect on that a little bit. I think that most of you are probably here and aware because of this sort of vast volume of these new AI or digital products that we're constantly being bombarded with. And many of them, I think, have the real potential to really enhance and improve the care, make things so much more efficient. But as GP practices, as partners, as data controllers, we do have a responsibility to ensure that they are meeting with the governance sort of rules around data, and also just ensuring that they are clinically safe to use. And the whole idea about this webinar was to try and kind of get that across. And so practices have an idea of what they need to do. Since we set this webinar up, there have been a number of different documents that have been released that have summarised it. There's an NHS England document called Guidance on the Use of AI-Enabled Ambient Scribing Products. And recently, we've just had some information from the BMA, which has also reviewed it. And again, we can share those documents afterwards, but they're very helpful and help sort of signpost where we need to be going. So that's kind of where we're here. So what we're going to do, we're going to just, Maya and Dan, I think, Dan, are going to just talk through some of the guidance. And then at the end of it, we're just going to have some open Q&As, which we'll probably do either in the chat or putting your hand up. We'll just see there's quite a lot of people here. And then afterwards, we will be producing some notes and Q's and A's as well. So Maya, can I hand over to you? Is that okay?
Yeah, thanks, Jack. I'm gonna just try and share my screen. Can you just give me a nod if you can see that? Yeah, perfect. Great. So yeah, as Jack's quite rightly said, there is a lot of technologies, digital AI that is coming straight in the eyes of general practice. And it's difficult to know if you're in a practice setting, who's a good digital company? Have they got the right things that they need to operate within the NHS? Are they going to be good for us as the providers of care? Are they going to be good for patients receiving care? So there are some rules and regulations, as you can imagine, in order to deploy a digital clinical product into the NHS. And some of those are not widely known about, and up until a few years ago, I'd probably include myself in that as well. And it's evolving and all the time. So what we wanted to do is basically just lay out what your kind of obligations are, the things that you should be asking for, and why. And we can talk about specific types of products like ambient AI, like Heidi and Tortoise and Tandem and all those kinds of things, if that's useful. But this is just kind of aimed a little bit more generically, because this is the kind of stuff that you'll need to know if you're deploying any product into your practice. So we want to support safe, legal and efficient adoption of digital tools in general practice. If any of you know me, then you'll know that I'm super keen on trying new things, innovation and getting that out into primary care. I think general practice is the most innovative part of the NHS. But we also need to raise awareness of the rules, information governance, legal obligations, and what NHS England have advised us around digital clinical safety. And we'll kind of have a bit of a support slide around roles, responsibilities, email addresses, those kinds of things as well. So this is the kind of obvious stuff, why do we need digital clinical governance? It ensures clinical safety. We are data controllers in general practice, so we need to protect the data that we hold, and we have accountability on that. And the ICB has some accountability because it has the DPO function. So Dan is the overall DPO for general practice. The risks, obviously CQC are around, and they might ask you if you've got your DPIA for the flash new product that you're showing them that's helping you do your work. With data governance, particularly, that's the ICO, so they can investigate and fine you. And obviously, there's patient harm if you deploy something that isn't safe. And this is all part of promoting a safety culture and continuous improvement, which I think is a really key part of what you're trying to do when you're deploying a new product. It's about kind of getting your whole practice on board and continually improving that, not just kind of letting it run and then walking away. So Dan could I'm sure we'll talk about DPIAs for the next hour, but I'm just going to say you need one. And you need it before you get started, before you deploy any product. So you need to speak to the DPO function in the ICB early on. DCB 0160, there is also something called the DCB 0129, which comes from the supplier. And this is the kind of hazards or things that might go wrong with the digital product and the mitigations that the supplier has put into place. So the DCB 0129 comes from the supplier. Equally with the DTAC, that's the digital technology assessment criteria. So this is like a catch-all for all the things that, or for the majority of things that you need in order to deploy into the NHS. And the DCB 0160 is from the provider side. So you as a provider, as a GP surgery, you need to be compliant with DCB 0160, which is basically a hazard log. So you have a look at their 129, which is also a spreadsheet of hazards and their mitigations. And then you look at that from a practice perspective and look at your hazards. What happens if it crashes and you can't use it? What's your mitigation for that? And then you risk score those mitigations, just like you might do for any kind of business continuity plan or other kind of risk assessments that you might do in practice. So I'm going to come into a little bit more detail because that's kind of where I kind of come in. But yeah, DTAC, you should ask the supplier if they've got that. You should ask if they've got DCB 0129. You should think about privacy notices. So that is your declaration on your website about how you're handling people's data. So if you're utilizing AI, you should be saying that in your privacy notice. And we're talking about obviously complying with CQC and the ICO. There is AI guidance that's coming up. It's coming up quite slowly. Jack has kind of just signposted you to one document about AI scribes in particular. So this is, a live regulatory environment, if you like. So we're kind of building the regulation as we go, because obviously regulation is always slower than kind of innovation. Dan, do you want to come in?
Yeah, I just thought as we're on this point, it'd be quite useful just to cover a couple of little bits.
Yeah, go for it.
Especially you just mentioned AI regulation, which I put my hand up before you started that. Obviously, there's next to none, and actually a lot of the regulators are kind of fighting for a bit of a position on that as well, including the ICO themselves. I was actually the ICO before I came here back in 2023. Sorry, my voice isn't. I've not been particularly well, so my voice hasn't come back yet. Anyone know a doctor? That'd be useful. But with the ICO, there's always a historic position that they wouldn't fine public sector because it's public money, so there's no point. The position changed just before I left early 23. They're known not for fining. So anyone that works in data protection will tell you they are pretty toothless when it comes to actually fining, but they are very good at coming in and turning over stones. And we've got a number of trusts at the moment in Kent and Medway that have got ICO involvement, whether it be through individual complaints or larger issues like sort of SAR responses and things like that. So the reason I just wanted to come in there is part of the obligation as a data controller is you know what happens with your data and what you're doing, what system you're taking on, how it's going to work, because you are the custodians of your patient's data. Although they wouldn't necessarily fine you, they have changed their position, so that could come in, and we always have to be mindful of that. But the fact that we're covering DPIAs and the fact that we're doing all this work to try and understand what's going on goes a long way to mitigate any issues that we may face. So it could be just a simple kind of, thanks for letting us know, what's your action plan to get this turned around in the next 3 months, done, dusted, nothing to worry about. Or it could be something a bit more significant where they want to come in and look at everything. So that's why, and I know we'll get to it later around DPIAs, etc., specifically, but that's one of the reasons we kind of need you guys to think about it as I need to do this for my own good, my own data, because it protects you later on. But on top of that, on a previous slide, Maya mentioned continuous improvement. So my background's in transformation, Six Sigma, continuous improvement as well. This stuff, the DPIA, your processes, your day-to-day, how you can use this system, that's going to inform your continuous improvement. So although it feels like an onerous task and something that, well, I don't know what I should be doing here, that's why my team are here to help you understand. But one of the reasons we ask you guys to kind of understand a bit more about the products you're using is because the more you know, the easier it's going to be to develop and improve later on. Or if you make a move from, say, a free version of something to a paid version. So these are all important in their own right for regulation and for ticking boxes, but they're even more important as a foundation for that, the efficiency savings that you're looking to make, or the time that you're looking to save in surgery to give back to patients. So try and look at all this stuff from that angle, not just, I've got to cover this box because someone told me somewhere that I had to do it. So I just wanted to quickly jump in there as we covered that.
Thanks, Dan. Okay, so NHS England isn't that helpful on where the roles and responsibilities kind of lie in terms of doing this work, but it's pretty clear in kind of Kenton Medway because we have the DPO function in the ICB. So they are your kind of go-to people to kind of start the process. Say, I'm thinking about this solution. What do you think? And for products that we deploy as an ICB, we will do that IG side, that we will do the DPIA, and we will do the clinical safety case. But if you are procuring as a practice, then you're obviously that responsibility lies with you, but we are here to help you as much as we can. But we can't do, and I'm going to take the words out of Dan's mouth, we can't do the work for you. So we can help advise you and steer you in the right direction, but we can't actually do the work for you. And the method we're trying to utilize is for because there are so many new products, we can't just kind of do DPIs for everything out there, because there's 177 practices, a lot of you guys, and one of me, and 3 in Dan's team. So what we are trying to do is where we think, well, we have an idea, there is a product that is coming live and it's interesting, let's take Heidi, that the first practice to kind of latch onto this and go, yeah, we want to do this, they go through the process with the DPO team of getting that kind of understanding on both sides of what the platform is for, how the data flows, what are the risks, all that kind of stuff, to create this first DPIA. And then and that will take a bit of backwards and forwards, so both sides can understand what the full scope of the product, and then the DPO function will kind of template that DPIA, so other practices can not start from scratch but start with that template. As Dan, I'm sure will say, every practice, as we know, is slightly different. So, and some, models are slightly different, where some practices or some PCNs are trying to deploy a bit of software across a whole PCN, and then they might have different data flows, or they might be utilizing the platform in a slightly different way, and then that might affect your DPIA. So it's not just a kind of well, here's the template DPIA, let's just put my practice header on it, and then we're done, we're good to go. You still kind of need to go through that process with Dan's team, just to kind of understand that, yeah, you're utilizing it in the same way, this is pretty much good to go, or actually we'll need to change some stuff because you're using it in a slightly different way. And sometimes with the with some of these products, with a free version, you only get some of the capability, so that DPI is different to the full version where you get different capability, and therefore the data flows, how it's stored, all that kind of stuff might be different. So there is a method that sits behind this. So what I've just kind of outlined here is a really kind of simple thought process that you should probably go through. So we always kind of say it should be people, process, and technology, not just technology and then get it in and then see how it works out. So identify what your need is, what the problem you're looking to solve. So with Heidi or Tortoise or any of the ambient AI scribes, it might be to reduce cognitive burden on the workforce and improve the patient experience by giving more attention to the patient in front of you, and therefore having a much nicer experience in consulting. So that's the problem you're trying to solve, and it might help increase some capacity in some way. And then have a look at the tools that are out there. So if we took ambient AI scribes, there's Heidi, there's Tortoise, there's Tandem, there's other players that are kind of coming into the market on an almost weekly basis. Have a discussion with this with your practice team, and if you've got a digital transformation lead in your PCN, talk to them as well. I have advertised rounds on the bulletin and things to reset our digital champions network. We've had 43 people come back, and so I think now this is almost becoming a specialty role in general practice, having someone who's pointed at digital and data and tech in general. So if you haven't got one, then I think you should probably think about getting someone who has got that kind of skill set, and then think about well, we know what the pros are, but what are the potential risks and what are the data flows? Because those are the things that are going to feed into your DPIA and your risk assessments. So before you procure something, make sure you know what you need, check the suppliers, request a DPIA from the supplier. If you've got it narrowed down to 2 or 3, request their DTAC, request their DCB 0129. If they say, oh, we haven't got any of that stuff, that's a red flag. So they should have this stuff. And we do know that there are companies that are just starting up who actually don't know what they don't know either, and then are just going direct to general practice. So don't get trapped by signing up to some platform that isn't compliant, and then you only find out from Dan's team afterwards that they haven't got some basic stuff in place. So get on the front foot, ask for those kinds of things. Dan, do you want to add anything into that bit, just in terms of involving the DPO team?
Yeah, I mean, the only thing I would say is it's not uncommon that we get requests from surgeries or people, because obviously more than just a DPO team, where they don't have those things in place. But we were happy to advise, we're happy to still work with you, but it just slows things down. If we know that they haven't got that ahead of time, then we can work out a way of at least advising you on potential timelines. It's usually this stuff comes up when we lift up some stones. So that's why it's a good idea just to see where they're at before you go. It doesn't mean it's an absolute no. It just means it's going to take you longer to get to that delivery point, assuming they're able to complete all those steps that they will need.
Yeah. So the newer to market the supplier is, the likelihood is it's going to take longer. And if they've got an AI component to it, then it might take longer as well, just because all of this is new for the whole NHS deploying an AI into the healthcare system. Now, one way we're trying to kind of make this easier is I have come across a platform called Bordercross, which is there to kind of automate the DCB 0160 compliance paperwork. And we're piloting this using the MOVC tool, so with Anima at the moment, and next will be AccuRx. And the idea is that you're supposed to hold a kind of a hazard workshop where you invite all the people who are going to be utilizing the tool and then have a discussion over the risks and the mitigations. This is quite an elegant solution that basically you can send out a questionnaire to the people in your practice or across the PCN, any footprint, and then ask what people think about, just through answering a bit of a questionnaire. And it will populate a hazard log, so a spreadsheet full of all of the risks and the mitigations. And then as a CSO, as a clinical safety officer, you just kind of score the risks and the mitigations, which is a much, much quicker process. And then it will also kind of produce the clinical safety case, which is your record. It's like the equivalent of the DPIA. So if you have the DPIA and your clinical safety case for any product that you have, then that is your stuff that you would show to the ICO and to CQC to show that you're compliant. So for those of you who have going live with Anima, you probably would have seen an email about utilizing this. Now, you as a general practice can go to Bordercross directly. Obviously, with my ICB hat on, I can't recommend them, but if you were to outsource a CSO function to SCW, for example, or CSU, that would cost you about 15 grand because it's quite a manual process. It isn't, I wouldn't say it's particularly specialized. You can train someone in your practice to become a clinical safety officer. It doesn't have to be a GP, it just needs to be a clinician. On the e-learning for health platform, there are some modules that you can go through. And then also there is a kind of a training kind of workshop session that used to be held by NHS Digitals or NHS England, which would kind of is the final tick in the box. So it doesn't take long. I know a few people have done the training and or have sent a pharmacist on the training or that kind of thing. Especially in those practices that are really keen on trying new stuff. So think about getting some kind of CSO experience in your PCN or even in your patch. It's not too difficult to do that. This Bordercross platform, I think, costs about 200 or 250 quid if you wanted to just outsource it. So that's what we're kind of testing it out because that's way cheaper. And that will give you your paperwork, and then you can send that up to the ICB and I can have a look at it, and it's a lot quicker. Otherwise, again, there's only me and 177 practices, so there's no way I could do those many kind of clinical safety cases. So you're going to have to do some work. During the procurement process, I would notify the ICB of potential suppliers just because we are moving to this DPIA template model. So if you say, oh, I've come across this great AI scribe, it's called Heidi, we'll be able to say, oh, here is the DPIA template for the free version, and then talk you through making that relevant to your setting. And then, complete the DPIA, DCB 016. The last bit of the puzzle is actually loading it onto your system. So that needs the digital IT team. So at the point of the process, as it currently stands, when you contact the DPO, because you need the DPIA before you can deploy, they will inform the IT team to give them the heads up that, look, here is something that someone wants to deploy into general practice. But they obviously do a different kind of technical analysis around cybersecurity and whether you can kind of some technical things that you can download it onto a computer basically. So in that way, we're trying to streamline it on the kind of the back office side. And then also we have a bit of a shared group between myself as a clinical safety officer, DPO function, and the GPIT team. So I can also, when I hear about a new product or a new thing, I can say, oh, look, this might be coming your way at some point with a practice. So we're trying to make it a little bit easier. So that's the kind of the current state of play. Dan, do you just want to talk about where we want to get to?
Yeah, first I was going to say, did anyone have any questions on any of that? Because I realised that Maya and I basically talked at you for however long we've been talking. I wondered if I did see a hand briefly go up, but I didn't catch the name.
Should we? Because there's 50 odd people. I think then we'll just kind of lose our trail. So maybe if we do this, and then we can do questions at the end, Dan, if that's all right.
No worries. Okay, so in terms of, I mean, Maya's just mentioned it there, thankfully, to save my voice a bit. But the DPO team have been discussing for a while now. Basically, when we get a new tool in, we want to create a template from it and work with the surgery to make sure we've got something robust enough that we can take off the sort of surgery specific information and feed that around. I think we sent Jack a copy of the free Heidi one, which I'll come on to in a minute. And the idea there is simply to speed up the kind of boring stuff, as I would call it, which is the BAU stuff that's going to be on every DPIA that isn't really going to change between surgeries, but we can review with each one we get just in case something happens. For example, the system that's being used may slightly change how they process stuff, so we can refresh them all at the same time. The idea of that at the moment is simply, as you would do, contact us. We're looking at this, brilliant. We've got a template. There you go. But for me, I think that's a step that feels a little bit unnecessary. So what's been built by a wonderful member of my team who has gone off on maternity, so she's not around to manage it, is basically a Pages, a self-serve kind of website based on Teams, which will sit in the GP DPO kind of team area where you've got the webinars and stuff that we would do, where we'll publish these templates into a library. So there's no personal information on there. They're not already signed. So no one can cheat the system or get any information they're not able to have. But it will be somewhere where you can go to get this information and just get a template and use it. And in there will also be some of the basic questions that we get quite regularly, in terms of we need advice on this topic. Yep, here's sort of the FAQs, if you like, which may well help you guys answer things a bit quicker, or on the flip side, have to wait less for us to respond, because the answers you need are already there. So we're trying to build something a bit more modern on no money, as with everything we're trying to do in the NHS. So it's built by my team in Teams, exactly how the front door works for the GP DPO. So it should have been launched already. It is there. So I need to speak to my team next week and see if we can get that rolled out properly. But once it's launched, we'll be regularly asking for feedback, and we'll be putting things on there, signposting to it, to try and make it a tool that you engage with, to save yourselves a bit of time and also keep us on our toes, to be perfectly honest, because like I say, we do get a lot of requests for things, but the more we as a team get used to preempting some of the things that are coming, especially in the world of AI, where it is a little bit more complex, and we can provide some updates, some advice, for everyone else, then it should be a lot easier for people as well. But in terms of how you approach us, I mean, a little while ago we introduced the digital front door, which is basically an MS Teams form. That was so that we could track the work. When I came in, it was pretty obvious there was some work going missing, using a generic mailbox all the time. That's going to continue, but it's going to be a bit more autonomous, or certainly with a bit more automation in it, I should say, with a move to monday.com, which will be in the next week or so. So the link will look different, the form will look different, process is exactly the same. Just means that we'll be able to update automatically, and you'll be able to send us all the files and paperwork that you need via that form. So for example, where Maya has mentioned, if you go out and get the evidence of DTAC, DCP 160, etc., you can actually attach that to the form you send us. So we've got everything already. So that's one thing, one advantage, one sort of time saver. But also we're aware that emails go back and forth, versions of documents. As part of the same site that we're putting we call it GP self-serve area. The idea is that we have folders for each practice for the work that we're working on. So there's one document in there. We can update it. You get notification of the comments. You can go in and review it, and it stays in the same place. And we work on it together. That saves the back and forth of different copies and email conversations and waiting to see if someone replies. So we're trying to do everything we can to make things a little bit easier going forward, without a budget to introduce a new system or develop a new system for everyone. So there will be some teething problems, no doubt, but obviously you can come straight to us, straight to me. Not a problem at all. But the whole idea of it is to almost double-edged sword in a sense that we want to give you all the information you need as a data controller, all the things that you're sort of obligated to know. Don't want you to be experts, because that's why we're there, but that will speed things up. You know, if you know a little bit more than you do now, and we have a little bit more information than we get now, it will speed things up. But it's that circle approach. You know, we get a little more information, we share that with you, you share it with us, and all of a sudden you'll end up in a position where you know exactly what you need to give us, we know exactly what we're going to get, and if we get anything new, we know exactly who to update for the next person that comes along. So that's what we're trying or endeavoring to do. And then once we've managed to launch that, we'll be, like I say, we're reaching out for feedback along those lines, because we, again, continuous improvement was mentioned earlier. We need to do that as well. It's not, you know, pressure's not all on one area. We need to try and lift it for everyone, especially given the unknown changes that may or may not happen coming up as well.
Great, thanks, Dan. So let me. Weirdly, my slides aren't moving. Oh, there we are. So yeah, so I think we've talked about that, haven't we? I'm keen that we move to questions. Oh yes, so I did want to talk about post-deployment surveillance. So this both a DPIA and your clinical safety case isn't a kind of a once and done. So it's supposed to be live for the length of the deployment of the software. So from commissioning all the way to decommissioning. Now, historically, I don't think anyone's been any good at that. But the reason why it becomes more important now is AI, because now people are starting to just implement AI into an existing platform. That wasn't in the original DPIA, it wasn't in the original clinical safety case. And AI is improving kind of week by week. So new features might come out. So you then have to also kind of think about, well, you know, how does that impact on risk and safety, which is why AI is, you know, it's a really big topic, because it's not like back in the day where we used to just like commission EMIS and commission DXS and it would just stay there for 10 years and nothing else changes. This is kind of changing, you know, week by week, month by month. So one of the reasons I like the border cross tool is you can then press on the, so you get your own personalized clinical safety case, but you can also just rerun the survey, which would therefore kind of fulfill that both post-deployment surveillance, because you get all the kind of the questions and the risks back again, so you can do repeat assessments. And that is a kind of a big question mark for the regulators around these AI tools. How do you make sure that post-market surveillance happens? And then obviously these kinds of, what you should do is if you have any issues with the platform that you're using, you know, you should feed that into your practice significant event process, you know, which I know we all do. So just make sure that, you know, any technology kind of failures go into that process as well, and then it will get discussed as a team, and then there will be a paperwork trail for that, which is always helpful for the likes of CQC and the ICO, should you ever unfortunately have to meet them. Oh yes, and there's some kind of contact details so that ICB digital team, that's the kind of the generic mailbox. For Dan's team, that's the DPO one. I've just put the kind of the generic email address for the CSO as well, because obviously I only work part-time for the ICB and they can help collate some of those things. And there is the website around digital clinical safety specifically, which talks about the DCB 0129s and 160s. It's got a nice little flow chart to see if you if a piece of software qualifies for DCB 0160 or 129. But I would probably say it's very safe to say that if it's being utilized in a GP practice, it will. But yeah, I just put that there for reference. So takeaways, last slide. You know, these are legal requirements for clinical safety and for information governance. We are trying to put some templates out there. There is some support. think about engaging with the TPO function early. And obviously you can always ask us from a clinical safety perspective as well, and communicate with the ICB, but also your staff. I think that's the most important thing before you start thinking about new tech. Your team needs to know about it. What often happens is you have one person who's, been to a conference or something like that and got really excited, comes home and says, right, we need to deploy this, but they're not the person that knows the data flows in the practice, who's going to do the DPIA, and they haven't really kind of discussed it as a whole. So that will really help with getting all your kind of safety checks in place. And I think that is it. Back to you, Jack.
Yeah, thanks, guys. I'm just having a quick flick through some of the questions. One of them was around, I think, Anima. So Anima was commissioned, wasn't it, for online consulting? And then there's this other tool that is AI Scribe that bolts on. And I think the question was, well, do I need to do
and I want
a DPIA or assessment for that? And I think the answer to that is yes, you do, because Anima was not procured and all the data governance around it was about it being an online consultation tool. So that's correct, isn't it, for that one?
Yeah. I was just typing a response to that as Mayo was
finishing
up,
okay,
saying exactly that. Yeah, we didn't procure that. It's basically an optional extra, but yes, you would need to, because it involves different data flows and a different purpose. But it shouldn't be too onerous to do because we're not reinventing the wheel. We can just add it as an addendum to the existing DPIA, so it should be, fingers crossed, straightforward.
Because I assume there'll be quite a lot of practices that are using Anima, because I suspect if you've got Anima, it probably keeps offering it to you, and you just click on a button and you can use it. So again, that would be so once you've done one of those and got a sort of template version, that would be available for practices to be able to use.
Right. Yeah, exactly right.
Okay. I just saw another question here. It says, are able to use any of these AI Scribe software as an individual clinician and a GP? And I think that just reflects the ease of which, you go to Heidi's website, you put your nhs.net and it just works. So the answer to that is no. You really do need to go through these processes before you start using them with patients for all the reasons that have been just explained. The fact that you can just do it and pick it up doesn't mean it's gone through the right processes for where you're working in your practice. So if you're keen to do it, you need to discuss it with your practice, have a look at these processes. And I know it seems, the thing is, all this stuff is kind of new to us as GPs, I feel, and some of the terminology and the hazard logs, it's all a bit new to us, but it is, because it is so new and there are these unusual inherent risks with it, it is really important that practices do it. And I think once you've got into the pattern of doing it, I don't think it will be quite as onerous as it might initially seem. And linked to that is this thing about a clinical safety officer that keeps being mentioned in lots of the sort of summary things that I think the NHSE have put out around AI Scribes. So in terms of being a clinical safety officer, the question was, could you have one for a PCN? And how is there? I don't think there's any. I think maybe Mayor mentioned this. There's no exact training about what you need to do. There's some e-learning for health stuff. Is that? And if you feel competent and therefore able to do it, then you could do it you need to be a clinician. What about having one person across a PCN? Would that sort of make sense, Dan or Mayor? Do you think would they be able to do that?
Yeah, 100%. There is, just to be clear, there is specific training to become a CSO. But even to get your head around it, you can do the e-learning for health modules, and that is the kind of the written work, if you like, for becoming a CSO. And there's lots of modules on there, so you can do all of those. And then there is a kind of, it was NHS Digital that used to run CSO sessions to kind of give you that final rubber stamping. So you can go through that whole process, having one person for a PCN or a federation. Maybe a federation might want to provide a CSO service for practices in the patch. Yeah, it's not a kind of a specific you have to have. It has to be an internal person.
Yeah. There's a really good question at the end there. Can you say which scribes have been approved so far? So are you able to respond to that, or what you've looked at so far? Because I know that you're also running a pilot on one called Tortoise, and we've mentioned Heidi, haven't we?
Yeah, so in terms of what things that we're testing out at the moment, so there is a DPIA template for Heidi, the free version, which Dan can kind of answer more on. There's also a DPIA, but only for the pilot that we're running at the moment, because that's a multi-site pilot with Tortoise, and we're running that with KCHFT, Maidstone Foundation Trust, 3GP practices, and social care as well. And that was really to see, is this technology any good? Is it safe? What are the best use cases? Just there will be an independent evaluation coming out in June, but spoiler alert is that it's very easy to use in general practice, and from a clinic setting perspective, all the feedback so far seems to be very positive. So I do think this is going to be a thing, and obviously NHS England have produced some national guidance. There could be potential national funding for AI scribes in the future. So in terms of what's been okayed, Dan, do you want to jump on that one?
It's a great question. I wish I knew the answer fully off the top of my head. Heidi free service has, and we're working on the DPA for the paid version. Heidi's an interesting one, and I don't. May have said something similar earlier. We can't recommend anything for commercial reasons at all, because otherwise we get taken to court for allowing someone else to be, or for purchasing something else. Heidi's quite a complex, not beast, but it has multiple different ways of using it, which means multiple different rules. So it can be, they'll provide a microphone, for example, which has its own connection. It can be through web, can be through a download. You can self-configure everything. So retention periods, when it actions stuff. So it is quite complex. It's taken a bit of time to get the free version written. There are other reasons as well. We've spoken to Heidi on a few matters, but that one I think will be the first one that's fully done. Tortoise is going through the evaluation period, so the reason, and this does come up a lot, can we use a DPIA for that? Unfortunately, no. From that trial or pilot, because that DPIA was created specifically for the pilot, which means it encompasses not just GPs, but where it's in hospitals, wherever it's being tested, it's all kind of one big document. And the agreement was that if it went beyond the pilot, i.e. we're happy with it, want to roll it out, we would need to recreate those DPIAs for the specific areas. That being said, if a practice wants to go off and get Tortoise themselves, I don't know what the funding element is post pilot, that will be one for Mayor to be put on the spot for. But if you want to go and get it yourself, then we will review the DPIA as we would do with everything else. But no one as yet, from my memory, has gone through that process. But Heidi's the only one that's been approved I can remember off the top of my head, but there are quite a few out there that do various little bits as well.
Yeah, thanks, Dan. It just struck, and I remember having this, I don't know the answer to this, but it seems a bit odd that every ICB in England is having to go through the same process on behalf of GP practices. And I think there's a sense from GPs that why is this not just done once nationally? And I don't know the answer. There might be good reason, but it feels like, because I know that with the Heidi one, for instance, we knew that other ICBs have been through the process a month or so back, which was causing a bit of tension because we've all got mates in different parts of the country. So yeah, I just wonder what your thoughts are on that.
Tom's got his hand up. I think you mentioned a comment earlier in the group or earlier in the chat that you can help answer this. So this might be interesting.
Yes, I came along because I suspected this might come up. So for those of you that don't know me, I'm a GP in Canterbury, and I'm the deputy chair of the Health Informatics Group at the RCGP. So these sorts of issues are, as you say, national issues. They've been discussed for years at the Joint GPIT Committee, which is where the General Practitioners Committee from the BMA, their digital leads come with our digital leads and argue with NHS. Seek agreement with NHS England on various things. The answer to this question is very similar to the answer to the question, why don't we have to pay for EMIS, but we have to pay for Heidi? And the answer is that if practice employs an AI at this stage, the practice is commissioning it themselves. Most of us are familiar with the GP systems of choice, because that was a very important contractual framework, and a lot of people are aware that it was replaced by the GP IT futures thing, but we've never had to engage in it, so we don't really know what it is. It's now part of an umbrella, which is the DSIC, the Digital Services for Integrated Care, and there's OCVC, basically lots of small acronyms. There is no framework for AI. There is no commissioning framework for AI. One will come, and probably sooner rather than later, but there's no light at the end of the tunnel from that point of view. So the answer to the question, if Heidi's gone through the process at NHS England, why there is no process, there is no assurance framework. NHS England haven't touched Heidi, and they won't. The only people who Heidi are accountable to are the MHRA, the Medicines Health Regulatory Authority. And the reason for that is that their product is a software medical device. But for most of the AIs, what you'll find is that the regulations ask them to check their own homework. So Heidi says, we're a manufacturer of a device, and MHRA go, okay, and that's it. And there's guidance to them as to how they should self-certify and so on. But that leaves practices in a rather vulnerable position, because if they take on an AI product, they are the commissioner. There is no assurance process. There is no regulatory body which has inspected anything. And so that's why practices are really shuffling very uncomfortably. And I'm very pleased and impressed with what you've presented today, guys. That the everything that you've said is absolutely correct, and the systems that you're setting up in order to support the practices is gold standard, exemplary. I'm very impressed, and I'll feed that back to college as we have these discussions. But that's why the practices will have to do extra work for it, because they're the commissioner and all of the legal responsibility falls on them. If the ICB said, right, we're giving you all Heidi, that's different. The ICB then is the commissioner. They have to provide the assurance, etc., etc., etc.
Thanks for that, Tom. That was brilliant. I'm pleased the call's recorded for that last little snippet. But it also highlights why it's so complex for us to review as well. So the self sort of declaration of software medical device came up very quickly when we were looking at it. The lack of regulation comes up. I think I mentioned it earlier on in the call. There's just so much complexity around it. But we, as my DPO team, there are other systems that don't have AI that have been approved by the ICBs, and we do get comments from people quite fairly. Well, it's been signed off over there. Why can't we just have it? And to be perfectly honest, the answer is, well, we've either reviewed what they've produced, and it's not been particularly good because the setup in different areas is different. You know, you've got the GP DPO team here, but in some ICBs they don't have that support. It's outsourced, or a lot of them will get their own. So there's no uniformity there. So for us, we just need to give our own due diligence to sign everything off at an equal quality, equal standing, so that the poor DPO doesn't get hauled over the coals when something goes wrong, i.e. me. So there's a bit of sort of self-preservation there. But yeah, that's essentially why. And just before we move on, there's a question that's been put in the chat twice, because I think he thought we might miss it, which is, can DPOAs be done by a PCN to cover all the surgeries in that PCN? Yes and no. Yes, you can. Create a template. We'd work with you for the whole PCN, but what we would need to know and work through and include would be the operating procedures of each surgery within it, because they may not always be the same. And in fact, there are the different operating models of a PCN as well. So where you've got a lead provider model, it's a lot easier to have one sort of set of documentation. If you've got a flat provider model, then it's a lot harder. But we would review it as a whole and then work through the individual surgeries as we go through, especially if the surgeries have got their own ICO reference, or whether the PCN itself's got its own. Generally, it's both. So yeah, so it can be done, but it's not as simple as just copy and paste.
Yeah, that's great. So I think that's the kind of, there was one query in there around this whole issue about whether that the AI scribes being medical devices and some of the things they can and can't do, which I think reflects a little bit what you said about them constantly evolving. And so I think there is a real difference between an AI scribe that simply listens to your conversation. It uses AI to listen, and actually it's really accurate. If you can just use it for dictation, but it then segments that whole kind of text into a clinical note, which is another bit of AI. And then with the Heidi free version, you can then choose just to put that in your notes, and you can edit it, and you're responsible for doing it. But other versions, other things might make suggestions of what you might want to do. Do you want to do a referral? And all of a sudden, when it starts suggesting things, that suddenly becomes a bit more complicated, because that's actually not just describing patient care, but starting to signpost you. So that's when this whole "is it a medical device" thing comes up, which is another layer of complexity, isn't it? On top of, if we're just talking about AI scribes, which is more a sort of descriptive sort of model. So that was just a response. I think Mark asked that one. Yeah.
Should we just mention consent as well, Jack? Because I think that fits in with
do.
kind of patient consent. So I think, that it's a bit of a blurry grey area as well. I think if you want to be completely safe, you would, if you're trialing this, then, you would put it on your privacy policy, you would engage with a PPG, you would put posters up saying we are using AI to make our, note taking quicker and more efficient. And then you could just kind of run that past the patient as you consult with, just before you consult with them. Okay, so that I think would be best practice. I think judging from all the pilots that we've kind of doing, there's not anyone that really goes, hang on, no, I don't want my consultation transcribed. No one really says that in practice from a patient perspective. But I think, part of using AI is to be open and transparent. So if everyone's kind of talking about it, then it kind of normalizes and it feels like there's nothing secretive happening in the background. In terms of, just to kind of let people know, in terms of that first bit, the kind of the free version where it's just taking what is being said and then turning it into notes, you could argue is under implied consent, because patients know already when they're coming into a consultation room, they're going to have a confidential conversation, but then it's going to go into their clinical notes. So some scribe people will say that's implied consent. You don't need to consent them again once they're in the room. But I think, each practice will need to take a view on that. So I've set out what I think should be best practice, but just to put that out there, that's what some people might say.
Yeah,
it's probably worth calling out, just to add an extra layer of complexity there, is that what I'm looking for at the moment as a non-risk averse DPO is that I think, based on what you said there, Mayor, as legitimate interest, I think you probably could get away with covering it under direct care and public tasks, to be perfectly honest, to do this, because it's part of your day-to-day, and that's what I'm exploring at the moment, to see how we can comfortably cover that, which will mean you won't necessarily need to say, this is what we're going to do, do you consent? Especially if it's already in your privacy policy, because you're already telling people that you're doing it. So that's kind of what I'm trying to push through at the moment, just to save a bit of time and effort for everyone, because I don't think it is necessary to ask every time. When it was brand new, when we looked at it for the first time last year, or when AI scribes suddenly became more of a thing or fashionable, it was very much for extra safety. I think there was one particular case where we said, no, you need to ask for permission, because I think it was only one or two GPs out of the whole surgery wanted to use it. So it was a very niche case. But in this case, I think if your surgery is going to be using it, then I think there is an argument we could sign that off. And the things like privacy policy, they're coming in for a consultation, so you're going to speak to them regardless of whether they want it recorded or not. For that, I think there's more than enough risk mitigation there to cover it under public tasks, really. So yeah,
that would seem sensible to me as well. It doesn't sound dissimilar to, a lot of us record our phone calls, and we don't. I remember when I first started doing that, I used to tell people, do you mind if I record, it's recorded? But obviously we don't do that now. It's part of It's on our privacy notices, often on our answer phone messages, all that sort of stuff. So people are often aware. So it feel like, yeah, I'm glad you're going along those lines, Dan, because it's one of those things I just think everyone will forget because you've got to say, actually, when you're seeing a patient, your focus is and should be on like the clinical, what's going on clinically with the person. And yeah, and I think these tools have the potential to improve that, don't they? Because that's the whole point. Because if you're presumably, if you're not having to type your notes, I spend a lot of time looking at my screen, typing my notes, and I'm thinking, if I don't do that, I'm going to be kind of having a better conversation with the patient. So you don't, yeah, that's interesting. One thing I just wondered, is it worth at some point in the future kind of having a look at what AI scribes are out there? I've just landed this on you, Dan and Mayor, but I just think so AI scribe is the thing we're being asked the most about. And obviously, I think there sounds like there's Anima, there's Heidi, there's Tortoise, and then there's Tandem. It might be quite good just because I think we've not really gone into the detail and we haven't got time to do that about what these scribes do, but I just wonder if it might be helpful to do that as well, even if we just had some practices or something like that, 5 or 10 minutes on each, just, this is what they all do, this is how they're a bit different. That might be quite helpful.
Yeah, and what I will do then is plug the Digital Champions network. So if you want to join that network, or if you want to send your digital lead, then that's probably the space to do that for those people who are kind of interested in that. And we'll set up Lunch and Learn channel. So
yeah,
if you're not part of the GP SIP channel, then please do join the GP SIP channel, which is a Microsoft Teams channel where there's over 560 people. I'm conscious I want to do more in the co-production space with people who are working in primary care, and so there's less people just making individual decisions that impact the whole of primary care. So that's the opportunity for that. And I just wanted to say as well, we're also rolling out Joy, which is the social prescribing platform, and they are also going to be releasing an AI scribe, and that's something that has been commissioned already by the ICB. Obviously, I've only just heard that news, and that hasn't gone through the DPO process, but that's just kind of floated out there. Dan,
hasn't gone through the DPO process, and you want to call me?
That's what I'm saying.
Come on.
But it will.
I don't want to move on with that. Correct. Mark's puts a really good point in the chat around accuracy of AI scribes. If anyone's sat through any conversation with a company looking to sell this, that's one of the big things they pick out when they're good at it. They don't stop talking about how accurate it is. And there's a lot of training has gone on certain models, which is why I talk about different levels of AI, like machine learning, large language, stuff like that. And what they use your data for. So they're the kind of things you need to look out for with anything AI scribe wise. Some of them, and there are hundreds out there, some of them will want to use your data in perpetuity. So the recordings to keep training their tool. So they're essentially going to be making money off you early adopters. That's something that nobody really wants, and actually you don't necessarily need. That's a very old school view of it. But that's where they've been trained, and actually Heidi, Tortoise, they're really, really good. I think that's an old view where the accuracy is not so good, but I've not come across any that we've reviewed where we've had live demos and it hasn't been spot on. And also the accent recognition is really good. So obviously Alexa was the first thing that really did that. Actually, BBC was miles ahead of Alexa on accent recognition, weirdly. But that's also been picked up. So yeah, just things. If you are going to look at scribes, they're the things to kind of look out on. What are they going to use your data for, and also how accurate they are claiming to be. And always ask for a live demo. Don't say, "Oh, we prepared this earlier for you," because anyone can do that and make it look good.
Right. Well, I think we've come to the end. So it's approaching 2 o'clock. So just to tell everyone, what we'll do, we'll send around in our comms a link to this, and there'll be some notes that go along with it. and we'll sort of try and summarise all the chats and questions as well, if that makes sense. And obviously, if you've got further questions, you can ask, but the DPO team, that their emails will be on the presentations. So thank you very much. Have you guys got anything else that you wanted to add finally at the end? I hope that's been useful for everyone. I appreciate lots of people have joined, and that's really good. So thank you very much for joining, everyone.
Thank you.
Cheers, folks.